Reg, and I know my seniors, Ms. Njiwe, Kalkalo, when they are celebrating the 100 years of Rondigen, since they discovered X-ray. So you are here, as we had just finished around 2 months in college. So it's only that now I'm different, I'm a bit white in my head, so maybe, and so many other things. So let's start. Mine will be actually like the marriages between X-ray, MRI, CT, nuclear medicine, and ultrasound. All those things are interdependent. There's no way we'll, even with the technology, we'll never forget what MRI can do for us or an X-ray can do for us. Still after our MRI, we'll hear doctors saying, I need a complementary X-ray. So wherever I am, that was my beginning. Radiographer, and I can myself go with the patient and do that X-ray. Don't say, I do it. No, our baseline is MRI. I mean X-ray. So that's a bit MRI. This, oh man, is saying low. A minute for the power. So MRI, PET MRI is the latest in the continent. You only have one in Egypt, none in any part of Africa, part of Egypt. So you can see you are still developing so many things. So that's why hybrid imaging comes in. And specifically we'll discuss about brain disorders, drug lesions. The first image is a T1 sagittal image post-contrast. The one on the left, the colored one, is a PET MRI. You can see that when you do MRI, you have also what you normally call diffusion tensor imaging, DDI, where you normally track the images at the nerves. You get those red, blue, green colors. And it's the same thing that PET MRI is doing. All these things are interrelated. That's the brain we are talking about. And every time we are doing MRI brain, the doctor would like to know, where is the tumor? Is it on the frontal? Is it in the occipital? Pontine ankle? So that's what we expect. And every time we suspect the patient has no balance, you suspect that could be around the temporal region, left paralysis or right paralysis, could be one of the hemispheres of the brain. So you have that anatomy on your MRI T2 sagittal, showing us parts of the brain, gyria, brainstem, and the other is epithelial presentation. Because we are saying in radiology or in radiography in general, you can't do any pathology unless you know the anatomy. So that's the brain anatomy. She is dead, man.
Mbona ilikuwa inashikwa na inachaji na
sio ni unajua ni mwingine site
ni ofisi.
Mnasadala kidogo tu. Okay.
Yes, Lucy sabotage. Lucy.
Sabotage?
Sabotage. Unasema ni sabotage.
Ndio kuja uagishe.
Inachaje?
Ngoja.
Sasa ile kizima ilikuwa inawaka. Sasa ile kizima ilikuwa inawaka.
Okay, let's continue. We are talking about the anatomy. Those are a pictorial image. The other one is anatomy. MRI head, T2 image sagittal. So in the introductory, we have to discuss the key developments in medical imaging. Because MRI came the other day, just around 1973, is when actually we had MRI was discovered to be used for medical, especially with the introduction of computer, so they incorporated. And that's why MRI is still not new, like, it's not old like the X-ray and the CT. So we are saying the history of MRI is that MRI has revolutionized the field of medical imaging, providing a parallel insight of the human body. We normally say multiplanar, multi-sequential. MRI whereby it's given a lot of doctors easy time of reporting. Basically, the patient will have done something else, pariah mail, ultrasound, CT scan. Most of the patients are referred from those other imaging modalities. So that's what MRI has done, giving us a lot of history about the patient. And the advantage is that you have a T1, you have a T2, and so all those sequences. By the time you come to your diagnosis, you know exactly what it is. You know if it's a cyst, it's always dark in T1, bright on a T2. If it's an abscess, it will be bright on a T1 because of the pus. So in the history of MRI in 1969, Dr. Raymond Damadian advertised and demonstrated that MRI could differentiate cancerous cells from the cancerous ones. So that was way in 1969. And in 1978, he founded a company in America called FONA, Field Focused Nuclear Magnetic Resonance. At the moment, I think, as indicated there, they have about 15 of them in the centers in America. And 1988, they produced the first one. I think that was the first commercial MRI. That's 1980. When CT scan had already existed for some time. What do we know about MRI? First facts on MRI scanning. It is a non-invasive and painless procedure. First time, if you want to do a patient a procedure, you need to know exactly what's comfortable with the patient. Even if the patient is coming for, let's say, for some other procedures like CT, like biopsies, it's a minimal fashion. But the MRI, apart from the IV line, is non-invasive and painless procedure. Apart from the noise in the machine, there's nothing else that really will make the patient to feel any pain. The Damadian created the first MRI full body scanner, which he nicknamed the Indomitable. Meaning you would scan the patient from the head all the way to the angiojoint. That is whole body scanner, full body. You know those guys who in the centers, they do full body PET, always from the vertex of the head to the mid-thighs. You can see this is something for a long time, but we still practice now. So something indomitable is like incredible, something which is very important. It's like when you go to India, you always, the first time when you land, you see they have written Incredible India. So it's the same thing that this guy did here. Call the machine the Indomitable. It is extremely rare that a patient will experience side effects from an MRI scan. Apart from the one normally from the contrast, which are also very rare. They always say 1 in 10,000 people injected with gadolinium will experience. And most of us, we rarely do even 10 patients in a year. It's difficult. Technology advances have significantly reduced the scan time. When we trained in around 1997, I think the first MR was brought in the country for Professor Wazuna along Gong Road. That was the only MRI machine in the country at that time. So you could see that those old MRIs were like 0.3. To do a lumbar spine, you would spend about almost 1 hour, because one sequence was like 12 minutes times 3. Patient moves, you repeat. So, but with technology, we've managed to reduce the duration. Because the common artifact in MRI is not from the machine, it's always motion movement. I mean motion artifact. So number 4, when we discuss about the prevalence of MRI, we see that in Japan, they have so many scans, and there are about 48 machines for every 100,000 citizens. I think in our country, they took to every country, like almost 15 years ago, 13 years ago. Most of them are grounded, but they are still struggling, but they're also limited in what they could do. I remember knees, maybe and brain, and lumbar spine, the spine in general, but rarely did we manage to do any body scans. Some of the neurological disorders, or as by my heading, you have the stroke, under the neurological disorders, you have the seizures, Parkinson's disease, Alzheimer's disease. Another thing would be the brain masses, could be TB, glioblastoma, meningiomas, brain cancers, which could be mets or originating from the brain, and the brain abscesses. Those are some of the things we normally come across in our request cards. Now, go back to PET MRI, which I say we still have one only in the country. And as Mr. Wazike was saying, we are practicing not radiology. What do you say? I think he said something like that. It's not only in Kenya that we do this, even in other countries. It's upon yourself to train. It's actually individual. Then we come to these great people of SOP and G here to send yourself to where these things are done. I remember when I was looking for a place to do MRI training, not MRI training, PET MRI. I found so many places with PET CT. Then I found only 2 places with PET MRI. That's Apollo in India, and one in Tel Aviv called Sheba Hospital. So I say, let me start with Sheba. When I sent them my email, I think their language is Hebrew. They gave me an appointment to see a doctor. So I know they missed what I needed. I wanted a training, but they gave me an appointment to see a doctor. So that was like that. Then I didn't give up. I just got one in Apollo. Physically, I went there myself, but I didn't join there until I did one in Europe now. So remember, they are not developed, these centers. It's actually a clinical area that you can train because they don't have any colleges. So it's always about us to see where we can. In Kenya, you find a place, there is MRI, there is ultrasound, CT. Just join those people so that you learn the technique. By the time you can formalize your training, at least you're doing something. So, as per that, you're saying to assess the brain tumors and other disorders by using PET, that's positron emission tomography. Here again, we are coming back. MRI was non-ionizing radiation. But with the introduction of PET, there is some radiation, which is a result of annihilation, which is actually, we are talking about the nuclear now again, which is, again, MRI giving us radiation. PET and MRI provide complementary information in the study of human brain. Simultaneous PET MR data acquisition allows the spatial and temporal correlation of measured signal. The advantage is that when you are doing an MRI of, let's say, an abdomen, when you are querying MRI, at the same time you are querying PET, then you do what you call registering of the image. And that will give you a lot of information. The only system you are shooting the patient like in CT, you do MRI here. First, you do MRI routine, then the patient moves to the next counter or the country so that you do PET. But for this case, it is simultaneous. And the resolution will be very high and you'll never miss anything. Then we need to talk about bridging radiology and radiation oncology for precise radiation therapy. I think the commander talk of precision in imaging. Patients will come to MRI, will come to CT scan before they go to radiotherapy department. But we need, before they go, we give those guys in radiotherapy, the right report. That's why, to reduce the gaps between the findings of radiology and what radiotherapy will do, we need actually to have this, what we call bridging gaps between radiology and radiotherapy. Then we have what we say, what we know and still need to know. Remember, radiology is a fast-growing modality, or profession. Now all of us are working together. Now you have radiotherapy, you have ultrasound, you have MRI. Then under radiology now you have radiopharmaceuticals. You have to get people from the pharmaceuticals to produce for us these tracers that we use in PET. So as we say, the only thing that all of us we are deciding about must be with the benefits of the patient. Benefits of PET MRI vis-a-vis CT scan PET. So most accurate diagnosis and treatment. Already MRI is so sensitive when we are doing the tumors, in that when you combine now with, MRI itself is molecular. Now when you combine again with another molecular which is PET, the results are very high. Option, PET, MRI brain can detect abnormal findings that PET's CT misses in more than 50% of the cases. 50% of the cases is not a small number. If you do 100 MRIs, then 100 CTs, meaning if you miss 50, that's a big number. But MRI will rarely miss, at least 50+% compared to CT scan. Improve safety. From significant reduction of radiation exposure compared to PET-CT, PET MRI exposes patients to about 50% less. Anything is 50% less, 50% more. When it comes to radiation, we'll be happy for anything that will reduce the exposure. The only radiation the patient gets is from the radioisotope that we're injecting. Number 3 is convenience of 2 scans. The way we have said is simultaneous. You can't do MRI, then you come for the PET tomorrow. This will eliminate the time wasting and separate appointments. Then there's another line. The last one is, it is still advisable to correlate PET findings with other investigation like histopathology. If you want to say this prostate has about the way you normally say, what do we give this prostate? Breast, periods 2, periods 1, stage 1. You cannot rule out until you have something like PSA from the lab. That's why you have the histopathology. And in any case, most patients will be coming for us after doing these things. So it's about departments relying on one another. So what do we use for this PET imaging? We have what we call a tracer. Tracer or radioactive drug. For Kiswahili, it's a very small thing, but it will give you a lot of information. Wale watu wanakunywanga saa zingine, kuna watu wanasema amewekewa mchele, something like this. Small, but you lose your consciousness. So it's the same thing here, but it has to be sensitive and specific. That's why every time they are buying it, as we talk about contrast, CT contrast, about attenuation in iodine, here we talk about sensitivity and specificity. Because it has to be sensitive to what we are doing. FDG, which is the very common, is sensitive to sugar because of the glucose metabolism, but it is not specific. So you have to at least balance the two. So you have the fluorodeoxyglucose, which is the molecule used for bed tracer due to high glucose metabolism that tumor cells exhibit compared to surrounding healthy cells. Like the cancer cells, the tumor cells will also metabolize sugar rapidly. Cancer cells grow rapidly. That's why when you go to radiotherapy, they are the ones, when they first do what we call, I think, hormonal therapy, then followed by radiotherapy, they are the ones which are hit hard by the radiation because they are already sensitive due to hormonal therapy. So it's the same thing here. They are sensitive to FDG, which is a very common tracer we use. Then, most of our imaging, there is always some preparation. Be it ultrasound, the rear meal, there must be some minimum preparation. Here is saying patients with diabetes may not absorb the sugar in the radio tracer, which can affect the scan results. So that's why it's normally say starvation for about minimum of 4 hours. Because if you have sugar in your body, and again we are expecting the cells to excrete, it's difficult to metabolize the sugar. It's like when you're doing an ultrasound, you need the GB to be empty, you don't need to feed first. So it's the same thing here. So for FDG specifically, because it's sugar-based radio tracer, you must starve. So you'll be advised the way you're saying there's a protocol of doing something, there's also a checklist for MRI, PET. Then also they've come out with a way of reducing the radiation to the patient in what some centers call ultra-low dose in brain, FDG, PET MRI in clinical settings. The way you say a LARA principle, as low as feasibly achievable, it is the same thing here. Inject the patient in small dose as possible, so long as you cannot compromise of the image quality. Because when you compromise on image quality, you compromise on the findings. So it starts with the image quality. So you can see a good example here, giving 1 MBq per kilogram in exploration of neurocognitive disorders. Disorders like Alzheimer's, dementia, you don't need to really pump the patient with a lot of radioactive material. And it's telling us you can even go as less as 0.2, and you still have image quality that the doctor can make a report. That was a good example on how you can reduce as we involve in radiology. Other tracers that we use, we have 18 color images used mostly for PET, for PET prostate, PSMA, which is the latest, that's prostatic specific membrane, and that one is also used both in CT and MRI. The advantage for this, if I go back here, FDG, you can use for CT and you can use for MRI. So that's where none of these imaging modalities will be independent of the other. We are both sharing the tracer here, FDG. When you have, it's not like contrast, CT contrast different from MR contrast. Here we are using the same tracer. Okay. Then also we are saying we have 68 as gallium plotted for PET, specifically for neuroendocrine tumors like paraganglion diagnostics. That is actually for neuroendocrine. We use 68 gallium to detect it. So those are some of the examples which we normally use depending on the diagnosis. Because you need to prepare a patient so that you do the specific radioactivity that is needed using the right radio tracer. Need NBO, need nothing oral for the next, before 4 hours before the procedure, do a lot of water, but for children, of course, we have to reduce to 2 hours. And the radiopharmaceutical use is FDG18. This is giving an example, because before you do anything in any department, you have to have what we call SOP or manual book. If I come and I'm in your department, I don't do my things. I just go to this Bible and pick what we use. So you must have also the baseline for everything. The way you have a way of scanning a patient for CT, maybe for internal obstruction, is the same thing in PET. So brain disorder is any condition marked by disruption of normal functioning of the brain. Main causes include damaged brain tissue, neurons, and nerves. This will affect the ability to communicate with the rest part of the body. And these damages are maybe from the injuries, stroke, or even dementia itself. It spoils, there's no communication from the brain to other parts of the body because they are damaged. Alzheimer's disease is common. You can see the two images. That's that. We normally like nowadays doing 3D images. You can see there's a volume loss. It's an old image, gray area, the white region. So that patient suffering from dementia, if you give contrast, it's advisable to do a 3D image, which is actually, we normally say a Canadian image. So even with an X-ray, no, with a CT scan, you'll see the atrophy in the patient. You know that's actually dementia, which is related to Alzheimer's disease, and you must give the patient a contrast. Composite image. First image is, first one is combination of PET and MR image. You can see like the diffusion denser imaging, you can see the nerves that's around the gray region. Then you have the post-processed image, which is green. Then routine images on the T2 flare. Then the PET image, the smallest is the PET image when you are down right. So this has made it possible. The doctors, it's so difficult to miss the report. You have MRI, you have PET, then you combine the two, and most likely this patient was coming from something else like a CT scan. So difficult to make a report. That's why most people in Europe are now combining artificial intelligence to make some of these reports. It's called composite image because there are two. Either CT image and a PET image, or a PET image and MR image. Still examples there. You can see the CT scan. There's a tumor on the frontal lobe, right? Frontal lobe. The center image is the composite image, and on the right is the PET image. So you can see it is red. We normally call that is hypermetabolic region. The tumor is metabolizing a lot of sugar. That's why it's actually a hot spot. That's what the doctors would like calling it hot spot. You come to T2 image, right frontal lobe. You can see some glosses on the flare. Go to the middle one, that is now PET stroke MR image. You can see still have that on the right frontal. Then the same PET image on the front side. So when you combine the two, you get that image. So PET image and the middle ones are composite image. So basically, it might be even apart from radiation, the CT will have been enough for this patient. You can see the findings are same. PET in the middle, PET in the center here. So basically, that will have been enough to do a CT scan for that patient. But the advantage of MRI is that you have the diffusion to see whether there's some what we call infarcts, which you can also see in CT, but if they are major. Same image here. This one, CT scan missed a large left hemisphere metastasis. Generally, the meds for the chest normally come for the brain are always mostly from the neck or from the chest. So you can see this patient. The first image on my right, the one rated A on my left, that is left hemisphere metastasis. Is visible from left to right. Axial coronal. You have the PET CT, the second image. Combine PET stroke CT. Then the last two, you can see the MRI image with contrast. That's number 3. That's what I'm pointing. That's the one. You can see these are met. Then we missed that one in CT. Yet there are two. There's a small one here, which you could not pick either on a CT PET, but you could pick from MR alone. And when you combine MR and PET, it was more obvious than the one here. So this is where PET MR will come in now. Then we have what is common, normally called intracranial epithelial abscess or subdural lymphedema. These are some of the abscesses that we normally find in the brain. And it's saying these are a collection of bursts which usually develop in the subdural or extradural space. The former is more common, more frequent. The common causes include complication of sinusitis, otitis media, mastitis, or surgical intervention. Sometimes somebody has already chronic sinusitis. When you do the brain, you find the patient has an infarct. So if that patient is only like 50 years and above, somebody will call it a stroke or an infarct, yet it is an emphysema. Symptoms of subdural lymphedema include fever, vomiting, exactly like somebody who was intracranial bleed, impaired consciousness, rapid development of neurological signs suggesting widespread involvement of one of the cerebral hemispheres. The diagnosis of choice will be enhanced MRI. If MRI is not available, contrast enhanced CT. Treatment will always involve not alone but surgical intervention. Is a patient who had nasopharyngeal squamous sarcoma, now presented meningism and seizures. Meningitis for patient with cell carcinoma, squamous cell carcinoma, and now developing meningitis and seizures. T2 image on our left, you can see on the right parietal region down there, you can see there is hyperintensity around this region here. Here, you can see there is something here. When you do a GRE echo, it's hyper. If it were black, it will have been blooming, dark. Continuation DWI, which is very important nowadays. You can see there is a lot of restrictions, frontal, parietal. This is because of abscesses. An abscess will restrict in MRI, it will be bright because there is no free movement of fluid around that region. T1 pre-contrast image sagittal. Around that level there, you can see it's hypo. For jet contrast, that's a T1 image. Most likely this patient suffering from either post-surgical or sinusitis chronic. That's why we have that, but we rule it out when you do contrast. At this level, we know it's an abscess. When you do your contrast, you can see now the dura is pushed from the all out from the skull is going to the brain now. There's a space here which is occupied by the pus. That's a T1 image. This level here. Then you have this one here also on the parietal side of the left. Then you have on the supratentorial region here. There's pus in between, and there's that capsule you're seeing. So this is emphysema, which actually is a rare, but it's always mistaken sometimes by our seniors. You may call it sometimes an infarct before you do contrast. So with contrast, you're able to pick it. Acute mastitis with subdural emphysema. You can see the left mastoid. When you do contrast, same level, just at the tentorial level here, it's enhancing. There is always an abscess, will always have a capsule around it. Subdural emphysema complicated by chronic frontal sinusitis, right side, and you may find this patient might have gone to see a ophthalmologist because they always affect the visual. But after doing it, you can see also the diffusion, which is very important. Parafalcine, it's around there, and there is that restriction. That's pus actually which is occupying those spaces. So I started from where we are. So let me just see how we arrive here. That's why now, history and evolution of brain tumor imaging. Generally, I wanted to start from where we are, then I go back now how we came to what we are discussing. That is radiography aid in diagnosis of intracranial lesion shows a calcified tumor of correct plexus arrow in a 20-year-old woman. There's a tumor here where that arrow is pointing. I don't know how many radiologists of this time can report tumor from lateral skull. I think they will be just the same day. You mention a tumor using an X-ray, maybe a fracture. But that's our people where we started from. Those guys could see a tumor. That's where the X-ray, and I think this was darkroom image. Wet processing, you can still see the film is not dry well. Then we come to this differential diagnosis of intracranial neoplasm by using cerebral angio, arteriogram showing parietal glioblastoma with a result dilatation of small vessels. I think at our time when we were training, we found this Dr. Wang and group doing Kenyatta. The angio they used to inject from the femoral, the groin here, and you could see this. So you can see the vessels are very prominent because of that tumor, neoplasm, which is actually going on in the brain. But you can see with contrast, this might not have been possible. But with contrast, it's helping us to see the tumor. These are initial images of MRI, CT scan and MRI. CT scan is the one on this. CT scan is this one here. There's CT scan on it. And this one is, I think this flare MRI. Shows compression of, sorry. Let's go back. Yes, here. You can see there's a tumor on the left side there. As from the, that's a 10-year-old boy with anaplastic astrocytoma. Astrocytoma is a very aggressive GBM. Let's say it's actually a GBM at stage 4. It's always very aggressive. And sometimes the patient will rarely survive 15 months when they have confirmed it is at the stage of astrocytoma. So you can see now MRI shows compression of the left ventricle and displacement of the midline due to compression from the mass. You can all of us see here, it's pushing towards the midline. This is an old image. You can see the X-ray, the MR, the CT here is showing us. So you must appreciate those people. With such images, they could actually write that report and say this astrocytoma. From X-ray, now they start now this thing they call multiplanar imaging. You do sagittal action. That's when now they started. That's around 1960. In 1960, Carl Australia reported in radiology the development of the first practical transverse or cross-sectional isotopic imaging method of brain lesions. So you can see now this image, CT scan obtained with EM scanner, lower the nasal region following almost the entire left temporal lobe, extending into parietal and frontal lobe representing astrocytomas. I don't know why all of them are calling it astrocytoma, but it must have been a reason. So you can see all of us here. Here, people came from far. If you present this to any doctor, nowadays is a criminal case. Yes, it should be actually. Again, that's where contrast started. Like I think we mentioned some ultrasound. I think Esther is the one who says something about 1947. I think also contrast started at that time. So you have this contrast. CT scan without contrast on A, post contrast on C. You could see there is midline shift. There is also phasogenic edema around the tumor, tumoral enhancement. So, before and after contrast for the GP, thalamic glioblastoma. So that's how the image was. I think there must have been one slice or something else at that time. Then we come to neuroplanning now, where it has matured. That's where we are at the moment. That is GBM multiform in a 70-year-old man. You can see clearly. Radiologists can see standing that this, even the technique, neurologist doing it. With that technique, they can tell there's a problem. That's a T1 post-contrast tumor in that image. TWI also came in. Restriction. What is telling us? This is not an infant. Whatever you are seeing here is some small restriction in the vision, visual weighted imaging. Possibilities of B1000 or brain 800. So you can still see MRI help a lot because you have an option of saying is it hemorrhagic tumor or not. So this one is telling us this tumor is not solid inside. Then we have now what you call advanced imaging, what you call perfusion neuroimaging, whereby you acquire a lot of images at the same time you are injecting contrast using an injector pump. That's what we normally prefer. And you run so many images and you can tell the way contrast is moving from one cell to the next one. So after processing, you can tell. So this is Very important, you can see that mass on the right. You pick it. We normally run about thousands of images because you do a number of series. Pre-contrast in the first almost 100 images, then the rest will be post-contrast. The doctor can make the kinetic graphs to tell the way you do in spectroscopy. So perfusion imaging is there also. Continuation, there is also post. You can see here imaging and spectroscopy in a 56 only suspect to knowing low-grade glioma. In spectroscopy, you cannot tell anything from the image. You can only see the processed image, which comes in form of a graph. You normally see the equalized lipids and the acetate. So you normally see when it is increased and when it's lowering, you can tell what kind of tumor it is because you normally deal with metabolites. Now we are what you call pre-operative functional MRI. Before a patient goes to theater in case of any brain tumors or masses, they always have to, I think MRI will be the last stage before they go to theater. So imaging localization of language and motor areas in a 37-year-old woman with recurrent left parietal neoplastic astrocytoma. So at least you see those two images, and it's showing us where the problem is. The advantage is that it's not causing any midline shift. So this will help the neurologist, neurosurgeon to perform his surgery. Then also, we are introducing also MRI in stem cell. You can see relationship between contrast enhanced and genetic expression pattern of GBM multiform. I think they talk about stem cell. I think it's still common in India. Before the patient goes for a stem cell, these are some of the things that will help the patient. You'll have the careful foundation on your left from the tumor. It is like what I think you talk about DNA sometime here. I think it was Commander who talked about it. So still the same you apply here. Before the patient goes for stem cell, they rely a lot from the report coming from the MRI. So this biopsy combined with spectroscopy will help the patient a lot, especially in knowing exactly what's happening and what can be the next management. So what are the ongoing developments? Magnets. We started with a 0.3, but unfortunately we are lacking behind. I think the government had only 2 MRIs above 1.5. It was Kenyatta. They had 1.5. They installed now 3 Tesla. MDRH. They've also installed 1.5. But the thing is that MDRH jumped from Lilium. They are now with the new, what you call coil of 01, the one they don't use any helium. They have 1.5, which are 3 in the country, where I work at German Medical, Gertrude Hospital, and now I am MDRH. I think it's 1 month old. So now we are moving away from the helium to helium-free. Coil is now in MRI. We don't use the ones we used to have transfer coils, receiver coils. Then we come to receivers. Now we move again from those coils to digital. Analog is whereby you used to get analog signal, we change it to digital, do what we call reformatting to form an image. But now we are having what we call digital coils. You get right away the signal and the image is formed. Then now you have the integration of AI. Most of these machines, the ones I've named, they have some AI component in it. They have some AI component in it. In fact, you do your spine, by the time you finish labeling it, so at least it's giving us some new hints. Then again, these protocols will never stop. Even before we have our colleagues, radiographers, have managed to, all of them practice in MRI. With helium, they are bringing helium-free. Before even we are starting with the CT scan, already PET CTs there. So all of us, we still have a challenge of what? New protocols being developed. You can imagine having only one PET MRI in Africa, which is in Egypt. It's Missouri Radiology Center. just one pet in the country. I think we have a number of pet CT scans in the country. So what we say, we work, we train as we work, and we train as we wait for the machine to come. We never wait for something to train. So that's the end of my presentation, and I say thank you so much.
Thank you very much. I think you should appreciate him towards the end. For now, for those of us who are not agreeing on everything, because most of us are doing like that, maybe you can have 3, 4, 5 questions. I think he has some time. So if there are any questions, please, can you have? Anybody? I'm an MRI service in which anybody there? Anybody there? Yeah, someone has a comment on this.
I just want to stress that when we talk of CT and MRI, it looks at the anatomy, but PET looks at the physiology. So if you combine the two, you get better the anatomy and the physiology of that water bottle. And also, if you are looking at a tumor, PET is able to give you the physiology of that tumor. How active is that tumor? So that method is used for characterization of the tumors.
Thank you. Thank you. Any other person? Martin.
So, thank you, Mr. Kyoko. Very right. That's why MRI is actually, PET is actually functional imaging. It's physiology and anatomy. Thanks so much.
Any other person?
Good afternoon. I just want to appreciate Tabot for the presentation, and I'm also amazed how technology is moving. We are still yet to learn the more analog technology in MRI, and now we are moving to the very digital. I just want to encourage my professional colleagues that we have to move with technology, but we are not going to lose what we have now, because we still need, I was just wondering, like, I'm teaching about the coils and all that, and Tabot is talking of helium-free and coil-less, because now we are going to digital. But all I can say is that is interesting, because we are headed there. And like he says, the first MRI, which was at Gom Road, which I had a privilege to use, it was taking more than an hour to do a scan, and now we are here doing a full scan, maybe 15 minutes or so. So we appreciate the technology, but we still move even at our pace. You know, where we are, we appreciate the pace we are moving at. So thank you, Tabot. Thank you.
Thank you. Any other?
Okay, thank you. I have a question regarding PET MRI correlation. And more specifically about the limitations of PET MRI, because when you're using PET, we're using what we call photomultipliers, which currently, or they have a difficult working a strong magnetic field. So how is the technology coming up to eradicate the limitations of such cases?
for any new technology, there is always some, even us as radiographers, you try not to change. But in MRI, as I give you an example, there you ask your question, we need only to develop protocols. These protocols will help us in one way. MRI is so dangerous when you go with a wheelchair which is not compatible. Up to the moment, we have about this country more than 20 MRIs. Some have been, I think some have been a bit fatal to that case. So what I will say, when it comes to the challenge of having a bed in CT, for to give a good example, we have a problem of cytol. How do we develop it? You need to use it within 4 hours. But still, in Kenya, I think it's Aga Khan which is producing. I think AU might come up with their own. So when it comes to that case, we cannot avoid it, but we have to go with it, but only manage the way we say when we come to students in our department. First thing in MRI is safety. So if the procedure has to be done, be it a biopsy, we have to see the risk first, the benefits. I can give a good example whereby there's still been a good debate. Do we give contrast during contrast for patient who is expected? The American, what we call JAMA, Channel Society of Physicians, said we've done about 452 expectant mothers with some with MRI, some were not on MRI, but there were no any change in like some symptoms in the children who had their parents scan. But that did not give us here in Kenya or anywhere around that I know that you keep on scanning patients who are expected before the 3 trimester. And no contrast at all for patients who already have who are expected. So that's something which is still under discussion. And it seems your question you picked from the European Society, because they are radiology, they normally talk exactly what you're saying. But we still have to manage with the little we have. I hope I have helped you.
Yes. Thank you very much. My brother Noah here. You'll agree with me, this gentleman is very passionate about MRI. Very passionate. It's such that whenever I come around, I sit around and listen to him, I always learn something new. Thank you very much. Now, can we appreciate him? No. Yeah, Havana. Anyway, so, because I know you guys are tired, can we stand up? Mwache kunodi sana. Hiyo namna hiyo, hapana. Sikia? Sasa anajua kule kwa tunaambiwa rais wa Arandogo, sio? Arandogo. Sasa huko ana nyingine hapa, sio? So utafanya hivi. Yule hawezi samahani. Sawa? Utafanya namna hii, sio? Fanya namna hii. Alafu sikize kwa 1, 2, 3. 1, 2, 3. 1, 2, alafu tupasue kwa moja. Sawa? Tayarisha. Na ukikosa tarejelea. Kwanza huyo. Haya, simpo tayari? Haya, tuanze. Thank you very much. Our next presenter is Andrea is coming online, so maybe Sydney, can you help us there, please?
Dr. Olanj, kindly if you can hear us, maybe you can be loading your presentation as we connect the system to physical attendance.
So you invite him, sir.
Yeah.
Let's go ahead. We need the power and permission to do that. So our next presenter is Dr. Raj. He's going to take us through GE contrast agents, but he's online, so just be patient, kiddo.
Dr. Olanj, you can speak. We test the mic and the. No, we can't hear you. Just a minute. I hope this is fine. Let's have a test with. Yeah, we can hear you from a distance. Okay, I think carry on. I will let you know.
Okay, so let me know when you take it from me. Sydney, can you hear me?
Yes, we can hear you.
Sydney, can you hear me? Sydney, okay, you can hear me?
Yes, we can hear you from the room. We're able to hear you, Dr. Olanj.
Okay, so and can you please see my guidance slide? I put on my guidance slide and I've shared it.
Yes, even in your slide, we can see them. The first one, expanding our reach in increase your option from G Healthcare.
Can, so, am I good to go? Me to start. I guess this means that next time I should travel to Nairobi because of technical difficulties. Making us excuses to visit the US. Sydney?
Yes, Dr. Olanj, carry on. We are able to hear you from our side. Yeah.
Just talking to myself for a long period of time, I would say that this kind of difficulty with technical setup inspires me to travel to Nairobi instead of presenting virtually. So this would be a good excuse to visit the country once in a while. So anyways, thank you for the
So, Dr. Holland, I hope you are not presenting because from our side we are waiting. This guy is presenting. Eh? You know, the speaker, which speaker is he using? Hmm? Na usinifanya nimechoka hivyo ndego ukiwa umeketi pale. Eh? Dr. Olaj, you can speak now, you see?
Yes, can I speak now?
Yeah, we had a
Can you
player
hear
guy,
me?
we will fight him here.
So, yeah, are we good?
You are good.
I think there's some echo, or I might be mistaken.
I will know.
I think you're ready, right? Okay, I guess that's a
Yeah.
positive sign. I can hear myself from the echo in the room. Anyway, I was talking about, before I was speaking to myself like a crazy person for 8 minutes or so, I was talking about the history and the collaboration of GE Healthcare with the people involved in MRI technology. So can you confirm that you can hear me, Sydney? Should I continue with the presentation? Sydney? Anyone? So the audience...
Yes,
in the room,
we are able to hear you, Dr. Olaj. Proceed.
Okay. Okay, great. Well, that's a relief. So I was saying, well, I was talking about history, and I was mentioning that back in the day, until 2017, as GE Healthcare, we only had one MRI contrast media product. It was a linear non-ionic product with the active ingredient gadolinium. The product is a well-known product. It's Omniscan, as you know. But back then, we thought that we only had a linear, so why not complete our portfolio by introducing a macrocyclic? And back then, we had two options. One would be to develop a new chemistry, which takes years and millions of dollars, as you know, to develop a new product. The second one was to introduce a branded generic from GE Healthcare, and that's the path that we chose. So the product, Dotarem, was available for generics manufacturing. It had lost its patent, so we decided to create our own generic of Dotarem, including cadaveric acid. So that's how we launched Clariscan in 2017. So by that move, we expanded our portfolio to offer you, our customers, a macrocyclic agent that is expertly manufactured by GE Healthcare. So as years passed, with the crisis of NSF and gadolinium deposition, stability became an important priority in the choice of gadolinium contrast agents, and the majority of the global healthcare industry shifted towards macrocyclic agents. And that is how we came to the market with Clariscan gazoteric acid from GE Healthcare. So the product is macrocyclic and ionic. It provides a cage-like structure that encloses and tightly binds the gadolinium ion in its center. Due to this ionicity and cage-like structure, it is highly stable and biologically inert. And as you know, the target is to have the gadolinium contrast agent remaining in the body until it has done its effect, and we want it to be eliminated as fast as feasible without being dissociated inside the body. That's why Clariscan provides you with a rapid biodistribution and elimination thanks to its chemical composition. Just like the the original molecule, Dotaram, we are an identical product. That's how we have obtained our definition as a generic. Clariscan contains the same amount of active ingredient as Dotaram, and the dosage is the same as Dotaram. So, as with all or almost all gadolinium contrast agents, the regular dose is 0.1 millimole per kilogram or 0.2 milliliters per kilogram. And it has been proven through studies that Clariscan has the same relaxivity as the reference molecule Dotaram. So you can use Clariscan for the same indications, the same patient populations, and at the same dosage as you would use any type of cadaveric acid, including Dotaram and Clariscan. The indications are identical, as I mentioned. So one of the biggest indications is central nervous system imaging. In this example, you see a 54-year-old female who came in suspected of metastases, was injected with 13 millimeters of Clariscan, and 2 suspected tumors were identified in the right hemisphere. Another popular indication for gadolinium enhanced contrast, enhanced MRI is our abdominal imaging. So here is another example of a abdominal imaging procedure of a 37-year-old female patient. The presentation was suspended and the final diagnosis was degenerative myeloma. Another image from head and neck region. This one is a 58-year-old female who presented with suspicion of parotid gland lipoma or liposarcoma. She was injected 17 mL of Clariscan intravenously, and parotid gland changes in line with lipoma were identified. So these are only a few examples, but I will in the coming slide mention that as Clariscan is a generic of is based on the same safety and efficiency documentation enjoyed by Dotaram, by cadaveric acid, and cadaveric acid has been in the market since 1980.
So it's my side.
A few notes regarding the patient populations. You can use the product in the elderly, neonates and children, but the indication for neonates and children excludes full body MRI in infants who are younger than
nijaribu na labi yangu.
Akutumia hiyo link alafu sasa wewe ufungue, then kwako itaendelea, then tu connect sasa usikia. So to haiwezi kataa bwana, hiyo ni sure bet.
Shida ndio mimi sina
sasa sisi wewe una login kama mtu anasikiza online, so itakukubalia email yako. Forward na simu. Naenda kwa nini kwa nini msema email yako haijafika. Email yako haijafika.
Acha nitumie na simu yako kidogo.
Ni forward kwa
Kama niliki masaa yake imeisha.
inaweza kuwa
Sio kwa active.
haiwezi kuwa late.
Na kwa nini zote zinakataa?
wanakupeleka Zoom direct.
But sasa unajua sina Zoom, silogin Zoom kwa simu. Oh, devices.
Nani ni host? Nani anafaa kukuleta in kwa meeting? Wewe ndio host. Kuleta in kama ni host. Sasa itaendelea.
Wewe ulikuwa unasikiza vile anasema.
Mbona hii kitu ni time kuread hapa?
Yes.
Mwongereza hapo kwa simu.
Trying to sort something.
Yeah, sure. I see that John is also online. Hi, John.
Merudi. Hebu leta HDMI hapa kwangu achilia. At least imejoin ya simu. We are good. We are good.
So we are okay, Dr. Olaj, from our side.
Yeah.
Yeah, you can hear you. 100%.
Any questions for me from the room?
So we'll get into the next presentation.
So
Unless there is someone with any questions, we have already listened to partially of it. I think we'll get in. I'm not sure, Kenneth, whether you have confirmed Washira is able to join us, but I was suggesting we get the presentation from Kibet, who is in the room. as we get ready with John Washila, who is going to do it virtually. Then in between, if you allow us,
John is already on the call, speaking for you.
Pardon?
I was saying that John is already on the call. I saw him earlier.
Yeah, if JP is on call, we can start with him. Then we finish. If you allow us, are you together with us up to the end, Dr. Raj?
Yes, I will do my best. So, when you say end, what time is that? I need to log off in half an hour or so?
Okay, we might go up to, for the next almost 1.5 hours at most.
Okay, then I won't be able to be with you until the end, but I will be with you for the next 30 minutes or so. If you have any questions for me, you can put it on the chat box or send it over through email, and I can respond later on.
Okay, we can put it in the chat box. Then you'll be able to see it before John is done with his presentation. John, are you? John, you can. Oscar, make John a co-host. Thanks. Dr. Olaj, let me see who is sharing. John, you are logging in under which gadget?
Sorry?
We can't see your name. Are you the one who is logging in with 212450608?
That number is straight to me. That doesn't show my name.
You can speak, yeah. Oscar?
I can share my screen.
Yeah, but you are not the co-host now. You are, yeah, you are co-host now.
Okay. I go ahead and share my screen.
Yeah. Go ahead and share your screen. What's maybe also you need to do on your side? With time, you need to re-edit the name in your gadget so that you can be able to log in when we can see your name. So share your screen.
Okay. So can you see my screen?
Yeah, we can see your screen, but you need to put it in presentation mode. We are seeing the slides, and at the same time we are seeing the presentation.
You're seeing what?
Good. Yes, you are there now. Go ahead.
Okay.
So,
all right.
Maybe you need me to do your introduction.
No introduction. We just go straight to the matter.
Okay.
I think we all know each other.
Okay. No. Not everyone who knows you.
Okay,
So-
I'm John Mashira, CG Application Specialist for G Healthcare.
Sir, thank you. So the audience are saying that you need to repeat that introduction. It's very fast. You are very fast.
All right.
Anyway,
fine.
all
Sorry.
right.
All right, I will repeat myself. My name is John Mashira. I am CT Application Specialist for G Healthcare. I had told Sydney that I would present on GSI application in CT, but today I want to start by giving an introduction to abdominal and cockroach multi-phase imaging. Another day we shall do the GSI application. Right, so the agenda is on contrast administration basics, contrast circulation phases, and examples and live demo. So now, contrast aligns to the image area by indirect means. That is to mean we inject through a vein, usually the median cubital, and the contrast reaches the aorta flow after going through the right cavities of the heart, the pulmonary circulation, and left cavities of the heart. Therefore, we can say it's the heart that sends it through the body. So the patient's cardiac output is an important factor. This process must be taken into account for the total estimation of arrival time of contrast. Now, in general terms, the whole timing might change, but we can estimate that we start with the 0 time, that is the start of the injection of contrast. After 5 seconds, the contrast will arrive at the superior vena cava. 8 to 12 seconds generally, depending on the cardiac output, the contrast will be the pulmonary arteries, and 10 to 14 seconds in the left cavities of the heart. So of course, contrast strength is an issue. Now, as contrast medium circulates, it is diluted by the blood, and the bolus disperses as it moves down through the circulatory system. That's a fact. Now, injection tips. If possible, choose antecubital rather than the distal column or the heart. Now, if you have to go upstream, that is to the arm, it is better the basilic, which is more medium, than the cephalic. Better right arm than the left arm to avoid innominated trunk, which will, of course, cause beam hardening artifacts from that concentrated contrast. A minimum in radiology, we emphasize that let's have minimum of 20 gauge and up to 4 cc per second, of course, depending on which examination. Avoid flexing of the arm, and of course, you can have very many references in these hyperrings. Now, let's talk about something called transient, okay. So there is a phenomena, I need to transient interruption of contrast here. So you can see that it was being hidden by the screen. So TIC is a flow artifact that consists of relatively poor contrast enhancement in the pulmonary arteries, while there is good enhancement in the superior vena cava, and also in the aorta, which seems not logical at all. Now, this vascular phenomenon occurs when the patient performs a deep inspiration just before the scan starts, resulting in increased venous return of unopacified blood from the inferior vena cava. So of course, we know that the blood goes into the right chambers of the heart through the inferior vena cava and the superior vena cava. So, unopacify blood from the IVC and then opacified blood from the SVC enters the right atrium, resulting in poor enhancement of the pulmonary arteries. This were capable of deep inspiration. Yeah, so basically, when we're telling the patient to breathe in, especially for the PE study, you may get poorly enhanced images in the pulmonary artery because of that phenomenon. So, amount of iodine, of course, injection policies might vary depending on the site, type of contrast. CDD, can I be able to get this? Okay, fine. So injection policies might vary depending on the site, type of contrast used, clinical intention. Always refer to the of course, to the site. As G personnel, I'm a G, applicator, and we don't prescribe the contrast protocol. There are different types, approaches through. Although the more correct, according to publication, is to adjust volume by patient size, using weight or body surface area. Now, and the body surface area is not a one-to-one adjustment because sometimes you may get obese patients who have fat, which will not dilute contrast. Because it's basically fat, it doesn't affect the muscles or the vascular visceral organs. In many protocols, a standard dose is given related to the weight of the patient. So weight below 100 cc. Of course, this is controversial because people are now into using less contrast in their departments for many reasons. The issue of the kidney and of course the scarcity of contrast across the world. Yeah, but weight 75 to 90 kilograms, 120 cc. And remember, we are dealing with the abdominal protocols. Weight greater than 70 kg, 150 cc. In some protocols, we always want to give the maximum dose of 150 cc, like when we are looking for a pancreatic carcinoma or liver metastasis. There is a formula here based on body surface area to calculate the amount of contrast that you might want to give. Now, injection 5 cc per second through an 18 gauge IV catheter for all indications, but especially for G breathing, liver tumor characterization, pancreatic carcinoma, pulmonary emboli. Use, for instance, a green venflon, test by fast injection of NC is seen almost manually. So don't test with the injector manually. Of course, checking how the patient is responding, and you're close to the patient. Hold the arm stretched. 3 to 4 cc per second if you're using a 20 gauge pink Venifone. If 5 cc per second is not possible, or because you are only interested in the lead photophase, then you can use the 3 to 4 cc per second. Okay, so let's deal with the contrast circulation phases. So abdominal imaging, so liver is a strong decipher for phases. So the first phase would be a non-enhanced. I want to mention here, when now we deal with GSI protocols, if there is a possibility of not doing the non-enhanced, just do the enhanced and use the GSI to remove the contrast for you later, and then you have a partial and enhanced face series. So the second series is early arterial phase, and then we have the third one, late arterial phase, hepatic or portovenous phase, nephrogenic phase, delayed or what we call equilibrium phase, delayed 1, delayed 2, which is excretion phase. So now the duo, there is the concept of the dual blood supply. The conspicuity of a liver lesion depends on the attenuation difference between the lesion and the normal liver. There is a dual blood supply to the liver. Normal parenchyma is supplied for 80% by the portal vein and only 20% by the hepatic artery. So the normal parenchyma will enhance maximally in the hepatic phase, which is at around 70 to 80 seconds after the injection, and only a little bit in the late arterial phase at 35-40 seconds. All liver tumors, however, get 100% of their blood supply from the hepatic artery. So hypervascular tumor will be best seen in the late arterial phase. On the other hand, a hypovascular liver tumor, however, will enhance poorly in the late arterial phase because it is hypovascular, and the surrounding liver does also enhance poorly in that phase. This tumor is best seen when the surrounding tissue enhances, that is in the late portal or hepatic phase, about 75 to 80 seconds post-injection. Now, non-enhanced, of course, is before injection, and we use it for detection of lesions that might be obscured by contrast, that is calcification, stones, etc. And even if it's, I would say, like when you use, like when, of course, you use like, you do maybe lower limb and the patient has a lot of calcifications, you're doing it like peripheral runoff, you have your aorta and the branches, you have a lot of calcifications. You can still be able to remove the calcifications and look at the calcifications alone, or you look at the calcifications alone, look at the images with calcifications included or with the calcifications excluded. Okay. Yeah. So you can measure baseline HU or Hounsfield units for enhancement, like in the case of neurohematoma in aneurysms. Fat-contained in tumors, that is lymatosis or myelolipomas. So the early arterial phase, you get this about 15 to 20 seconds post-injection or immediately after detection of a bolus. This is the phase when the contrast is still in the arteries and has not enhanced the organs and other soft tissues. Now this is an angio, so for vessel mapping, detection of vascular disease, dissection of vessels, etc. And then you can see tumors depending on the hepatic artery, the detection of HCC, invasions of arteries. Now, late arterial phase, we get it 30 seconds post-injection or 15 to 20 seconds after detection of a bolus. Sometimes it is called arterial phase or eye portovenous phase because some enhanced some enhancement of the hepatic veins. So enhancement of hepatic parenchyma, detection of hypovascular liver lesions, cysts, abscesses, e.g. colon adenocarcinoma metastases. Well, generally most metastases, you should be able to see the necrotic core. Now, nephrogenic phase is detected 100 seconds post-injection or 80 seconds after bolus tracking. This is when all of the renal parenchyma, including the medulla, enhances. Only in this phase, you will be able to detect small renal cell carcinomas. Enhancement of all renal parenchyma, including medulla, and you'll also have a detection of renal cell carcinoma, like you can see on the arrow in this illustration. Delayed phase 1 or equilibrium, approximately 2 minutes post-injection or 2 minutes after bolus tracking, used to rule out subspecific hepatic lesions like hemangiomas through their washout pattern. Enhancement of hepatic parenchyma, specific washout, detection of ruling out hepatic lesions. So you're seeing this is non-enhanced arterial phase, auto, and then equilibrium, and this is three-phase contrast enhanced CT demonstrating globular, peripheral, and centripetal enhancement, tending to homogenization in the equilibrium phase. So, 6 to 10 minutes post-injection or 6 to 10 minutes after bolus tracking, there is a washout of contrast in all abdominal structures except for fibrotic tissue. Because fibrotic tissue has a poor late washout and will become relatively dense compared to normal tissue. This is comparable to late enhancement of infarcted scar tissue in cardiac MRI. It is also used to assess the urinary tract and the bladder. So this is also used in the enhancement of scar tissue, kidney and urinary corrective system. And also the detection of cholangiocarcinoma, fibrotic metastases of breast cancer, kidney, urinary bladder, and sensational cell carcinoma. So, timing of contrast enhanced CT. Timing of CT series is important in order to grab the right moment of maximum contrast differences between a lesion and the non-parenchyma. In arterial, avoid being too early or too late. Smart play, now in the case of G systems, timing is very useful. Portovenous, avoid being early, at least 70 seconds delay. So we have images here, 18 seconds. You can see you have some arterial circulation shown there. Oh, sorry. Yeah, then you have the late arterial. So some lesions are starting to pick up the contrast. Late arterial, washout, and then you have the portovenous. So the late arterial, have washout of the. You have a bit of the artery, and then in the portovenous phase, we have now better opacification. Okay, examples. Also chest and liver. So let's Okay, so we say arterial phase. I'm getting some interruptions. Arterial phase, sometimes also called arterial phase or early portovenous phase, because some enhancement of the portal can be seen. All structures that get their blood supply from the arteries will show optimal enhancement, and this is used for the enhancement of hypervascular lesions, stomach, spleen, and pancreatic parenchyma, and then also the kidney cortex, and the picture is there for good reference. Then there is the detection of liver, hepatocellular carcinoma, FNH, adenoma, hepatocellular metastasis, pancreatic pancreas, adenocarcinoma, selenoma, bowel, ischemia, and hypernephrosis. And then, so in the abdomen and pelvis, we have the hepatic folate portophase, 70 to 80 seconds, contrast injection. Although hepatic phase is the most accurate term, most people, we picked that before. This is used for the enhancement of hepatic parenchyma and the detection of hypovascular liver lesions, cysts, abscesses, and colon adenocarcinomas, and of course most metastases. Okay. Good. That is at the end of my presentation. If there is any quick questions, we can deal with them. I think Cindy, probably we can share this presentation for interrogation.
Yes, John. Thank you for good presentation, and we are in agreement that the audience, he can share this. Yes. Wonderful. So, if you are able to share with us that presentation is good, and we can be able to work on it, even as we work in our workstation. I think, do we have any question for Dr. Olaj on the presentation he did for MRI, contrast media, and what John has done, maybe before we bring in Mr. Kibet? Anyone who has a question? So I would prefer, if we have a question, because we need to release Dr. Olaj. John, are you together in the next presentation? It will take us for about that minutes.
Yes, yes, I'll be here. I'll just remove my image.
Okay. So,
and mute myself.
Okay.
Yes,
so,
I'll be right here.
With that one, now I give over to the moderator to take us through, in case there is any question in the room.
Is there anybody any question, by the way? Anybody with any question? Andika mahali kama umesahau utakumbuka. Okay, time is not on our side. I think we need to call in the next presenter. Dennis Kibet. Anyone? I hope utakatia kama wale wengine.
Hi, good afternoon. Yeah, my name is Dennis Kibet. I'm the clinical education specialist for MRI from GE Healthcare. So before we start, First of all, I'll allow like 1 minute. You can stand and stretch, even if we are running out of time. Maybe you can just do a quick stretch before we proceed. Okay, you can sit. So how many of us are practicing MRI at our sites? By show of hands, so that I know the people I'm targeting. The audience is quite small for MR. So in line with today's theme, which is on the evolving role of imaging applications in modern clinical practice, I wanted to share some few advanced applications which we are offering as G Healthcare, especially on brain. Just a minute.
So just mute on the end.
Yeah, so today we'll only be covering neuro. There are a lot of other applications for body, MSK, cardiac. So today I'll only take through neuro. So we subdivide our applications that are available. To these 4 regions, so they can either assist us to scan faster, us to scan consistently. That means we reproduce our scans from one patient to the other, and also they can be able to provide quantitative, quantifiable measurements. And then the last one is to provide personalized. So I'll start with the first one. For first, so these are applications that can allow us to do accelerated imaging. So remember that when we are scanning fast, there is a trade-off that we have to lose on something. So if we are going faster, we have to always remember that. Sorry for multiple interruptions. That we have to maintain a good diagnostic quality of our images. So what are the solutions that we have for fast imaging? Is the RDL, deep learning healthcare. How does it work? So first of all, let's start with the challenges that you experience as you are scanning MR. So there are these 3 items that is a day-to-day challenge for the MR technologies to balance between them, which are the SNR, resolution, and scan time. So if you have a patient inside the scan room, you have to choose. Additionally, you cannot get both three at once. So let's say you want to do a high resolution imaging. What do? You either decrease on the slice thickness, increase on the matrix sizes, and what will happen on the resolution? The resolution, yes, will be good, but the scan time will be higher. In other cases, you have a patient who cannot tolerate a scan, so you want to scan faster. So you increase on the slice thickness, you reduce on the matrix sizes, especially on the face encoding steps. But what will happen on the resolution? Your resolution will decrease. So there is a balance that you have to choose in these two. And traditionally, what the technologies have been trying to work on is to either increase on the field strength, moving from 1.5 to 3 Tesla, therefore increasing on the SNR, but that comes at an additional cost. You have a 1.5 Tesla MR, you have to remove that MR and install another 3 Tesla, which is quite expensive. Installing higher gradient powers, as also the higher the gradient strength, the effect of high gradient fields like peripheral nerve stimulation also will come with that. Going to higher coils and parallel imaging, that also comes with a cost, additional cost, and using image filters. So how image filters works, they work on the processed image. So it's like the filter you use on your phones from Snapchat. You take a picture and then you use filter to enhance the already acquired image. And then use compressed sensing. Compressed sensing uses undersampling technique. So you're acquiring less data to go fast, which comes as a trade-off. So how does this AirRecon DL works? So AirRecon DL works on the raw data. That means we are working on the case-based information. So case-based is the time domain whereby you feel your signal that you feel you have acquired from the MR, you feel it to case-based. So AirRecon DL will try to noise from the case space before using this data now to post-process on your image, which is different from what filters does. Filter will work on the image that is already produced, but this AirRecon, which is a deep learning algorithm, will work on the raw data to denoise that. What will you achieve? You will be able to achieve a higher SNR and sharper images and more accurate images without sacrificing on the scan time. So we have two utilities for AirRecon DL. It can help us to improve on the SNR and also be able to scan faster. An example here is a phantom scan. So we have two phantom scans. On the left is on the traditional scans. So as you notice that within, as you go low from this magnified view, with the smaller ones, you notice that they tend to become more blurry. And also, we have this artifact known as the truncation or Gibbs artifact, which occurs because of data undersampling. But if we denoise this image by reducing the noise from the case space, we can be able to achieve, on the image on my right, you can see the images are more sharper, and there is reduced ringing Gibbs or truncation artifacts. An example is like this knee examination. So conventionally, if you want to achieve a good image resolution, from the image on my left here, you can see the pointer. From the screen, it will be the image on my right. So on the right image, the SNR is good, the image quality or the image resolution is optimal. But if you can see on the parameters down there, is that we are using a double excitation, and the scan time is 3 minutes and 24 seconds. So the scan is longer. And let's say we want to scan faster, what do we do? The available parameter here is to decrease the number of necks. So necks, basically, an analogy for necks is like painting. So if there's one line of case space, you have to write your information. And as a painter, you can paint it once, that line, or if you want the paint to become more visible, you can paint like twice or 3 times. For this case, basically, we are painting a line twice, but that comes at a cost. If you double the necks, you double the scan time, but you don't double the SNR. The SNR will only increase by square root of 2. So there is an increased scan time, yes, the image resolution will be good. So if you want to scan faster, we reduce the next to 1. We reduce the half time. We have the scan time to 1 minute and 56 seconds. But what will happen on our image resolution, the image at the center from the magnifying frame, you can see the image becomes noisy. So if we use the same raw data from the noisy image and we process it using the deep learning algorithm, we can be able to get the far left image, which is, has improved quality with the same scan time. We are able to scan faster. If you compare the image on the left and the image on the right, they're almost the same, and we are scanning at half the time. So other regions that are very challenging to scan, especially in 1.5 Tesla, is regions in like prostate. So using the PIRAT 2.1 guidelines, to scan prostate, we are required to scan 2 planes in T2, the fusion with ADC, perfusion, and perfusion. So the required parameters is to have less than 3 millimeters slice thickness and in-plane resolution for T2 at around 0.6 by 0.6 matrix sizes. So it becomes a challenge in scanning in 1.5 Tesla. And as you can see these images, we are using Airicon DL, and we are getting a very nice image quality. From the images at the middle, if you see the center image, so that is B800, below B800, we have synthetic B1400. This is a synthetic technique known as magic DWI. We are able to produce additional B values without additional scan time. So like prostate, normally we scan at around B0 and B800 to get the ADC maps, but the higher the B value you are getting, the better the lesion detection. So, but if you go higher to B1400 while scanning, the scan time becomes longer, and then your signal will be very low. The image basically becomes very noisy. But we can use B0, B800 and post-process it using the synthetic technique to generate B1400, which is better, and we have a better signal. So currently, as of 2024, that is March, these are the current installations that are using Airicon DL across the globe. So over 3,400, over 34 published articles, and over 24 million patients who are being scanned using this technique. Another advancement is using HyperSense. So for G-System, any Hyper is a group of technologies that help us to scan faster. So this HyperSense technique helps us to accelerate cube. Cube scans are basically volumetric high resolution scans for GEM by up to 50% the scan time. Similar to these are the images. As you can see, comparison between conventional and conventional with HyperSense and Airicon DL. If you compare the looks, you can notice significant improvement on the image quality. We also have Hypercube, works almost the same as HyperSense. These are just using compressed sense technology to improve on the scan time. As you can see from the axial for the C-spine images, so we are scanning at 2 millimeters, 0.6 by 0.6 matrix sizes. And we are able to achieve this in 1 minute and 29 seconds, which is a very fast time for volumetric high resolution scan. We also have Hyperband for functional MR, DWI, and DTI. So this technology, this type of imaging, you normally use as ecoplanar imaging. For ecoplanar imaging, we acquire one slice. So we are filling all lines for K-space using one TR. But we are acquiring one slice after the other. But when we use the hyperband technique, we can be able to excite multiple slices and acquire them once. These are some of the images for hyperband, showing DTI and fused images for fiber track and MRI. The second technique that you can use is to be able to achieve consistent imaging. So there are variations in MR and we have to be able to reproduce the image quality. Even if the patient tries to move, even if we scan faster, our image quality should be consistent all the time. The technologies that are available now to be able to achieve that, we have AX. AX is an automatic slice prescription technique offered by G Healthcare also. So this technique will automatically prescribe for you the slices. As you know, MRI, for different plans, you have to plan them all the time. So there's a lot of repetitive planning, and it consumes time also. So with this AX technology, as you can see from this video, for planning for brain, even if the patient changes position from one sequence to the other, the machine is automatically able to automatically prescribe. Therefore, we are able to scan 4 times faster and 5 times faster and 4 times less mouse clicks. So the planning to try to reduce on this plan, try to angle the coronal, sagittal, and axial. This is currently available for brain and knee. So this is an example of a patient who had serial scans, and this is just an MRI for brain. You can see the vessels. So this was the first time for the scan from my right to my left. So as you can compare, you see the anterior cerebral artery vessels. So because the technologies will use different planning, there might be some variation. Because this is the same patient, we are doing serial follow-ups. But you see there is a variation of the ACA and how it appears, and that may affect on how the radiologist is reporting. But on the images below, you can see consistently the same images are able to be reproduced using this AX technology. So the next, I'll just show you how we use AX for knee. This is the parameters. You only select the plane you want to acquire by selecting the anatomical plane. So if you, even for the advanced like ACL planning, sometimes it's very challenging for the junior technologist. You can plan knee, yes, but when it becomes specialized, the radiologists want to see the ACL or PCL planes, it becomes a challenge to get those oblique planes correctly. But with this technology, you can just select the plane you want, and the machine will automatically prescribe for you the slices. The next one is known as focused DWI, which basically means field of view, optimized and unconstrained, undistorted single-shot DWI. As you know, DWI, especially for parts like prostate, base of skull, it's normally very challenging to get good images because of the high susceptibility. So using this technique, we are able to achieve high-resolution single-shot images for the challenging parts. As you can see, this image for the base of skull, for spine, and even parts like prostate. Sometimes when we are scanning DWI for prostate, we have to scan the whole of the pelvic region. And yet our region of interest is just a small part in the pelvis. Because if you reduce the field of view, you get a lot of wraparound artifacts. But you can use this technique to scan those challenging regions, especially to get a high resolution small field of view. This next one is MUSE, multiplex sensitivity encoding. We're able to achieve multiphase acquisition. So in EPI, we can segment. Instead of filling the case space using one TR, we can be able to segment to multiple acquisition, therefore improving on the image quality and reducing susceptibility. The next, which is used with MUSE, is progress, which basically means polarity reverse on gradients to reduce susceptibility. It helps us reduce on the susceptibility artifacts which are commonly available in DWI. DWI, as you know, is an EPI sequence. It's very much susceptible to metals, air, especially around the temporal bones. As you can see on the image on my right, around the temporal region, you can see a lot of susceptibility there. So in case there is a restricted diffusion or there is a lesion, the radiologist may not be able to pick it very clearly. But on the left, using progress, it can be able to reduce on those susceptibility artifacts, improving on the image quality. The next one we know of it, the propeller technique, which is commonly available. Many vendors have them. GE, Propeller, Philips have the name, Siemens also have a name. Basically, we are using radial case-based sampling. So instead of filling using the Cartesian method, we fill using crisscrossing lines, and we oversample at the center. So when we oversample at the center, which has a more contrast, we are able to correct also for motions. This will only correct for motions where the patient is moving in plane, not in and outside the ball. So we also have an advanced one for advanced propeller, where we can also combine this with DWI also. Propeller DWI, very helpful also in scanning patients, especially if they have braces. If you scan DWI with patients with braces, you will normally get a lot of susceptibility. But you can use this DWI propeller to correct for that and also for motion. We also have 3D motion correction. For G is called PROMO, prospective motion correction. So we are using a radial navigator to correct for patient motion. From these videos, you can see the image on my right. This was acquired without PROMO. You can see some motion artifacts. The same patient was reacquired using PROMO technique, and you can see the images are more clear. So PROMO is specifically for 3D motion correction, and then Propeller we use it for 2D motion correction. For quantitative scans, right now radiology is moving towards delivering quantifiable scans. So we vary from subjective evaluation because it may have interpersonal variation. One person will be seeing something, another person will not be certain. But with quantifiable measurements, if you measure, you get a number. And that number, you just refer to it, and you can be able to offer precise diagnosis to lesions. So the first one we have is arterial speed labeling, which is an uncontrast brain perfusion technique. So we use a labeling delay pulse, which is transmitted towards the base of the skull of the patient, and we allow some time, and then we acquire the brain. So we subtract the images pre and post acquisition, and we now get this ASL, and we are able to get cerebral blood flow maps from this acquisition without giving any contrast. If we have to give contrast, we use this BrainStat technology, which is for brain perfusion, for contrast, and you can get multiple parametric maps from this. For quantitative pharmacokinetic mapping, we have GenIQ. This is also for T1 perfusion imaging. And then the last one is for personalized patient experience. This one will help us to be able to adapt to each patient. As we know, no patient is the same. Every patient is unique, and we have to be able, as the healthcare providers, to adapt to their needs. So the first one we have is the silent suit. MRI is widely known to every patient that it is very loud. So sometimes after scanning the patient, they go and tell their relatives that, that side the MRI was broken, and they were scanning me while they were repairing the machine. So because it's very noisy, initially we could not work around the noise, but right now we have silent technology. So this will be able to reduce the amount of noise in MR to around 3 decibels above the ambient noise. Okay. So this is very important, especially for children and geriatrics. So we are able to do sedation-free examination, and this technology also helps us to remove undefacing artifacts and reduce motion sensitivity. The other one is on vessel wall imaging. So using this motion sensitized driven equilibrium, we are able to suppress the signal from the blood, and therefore we can be able to see the walls very nicely. And this technology is compatible with fat suppression, so we can be able to differentiate between fat and calcified plaques also using this motion sensitized driven equilibrium. And then also we have a flexible ASL, which is a technique I mentioned before, non-contrast brain perfusion. With this flexible technique, when you're doing ASL, that time that you have to wait before you acquire will vary from a child to adult to an elderly person. Like for G system, for child we use 1.5 milliseconds, for adults between 2 to 2.5, and for geriatrics above 3. That is for elderly. So we are able to get better maps for ASL. The last one is bone imaging. This is a new technology that we are able to use zero-TE technique. So using this zero-TE technique, we can be able to visualize the most challenging part of MR, that is to see the bones. These are normally being reserved for CT and X-rays, but not all patients are candidates for those procedures, like pregnant patients, like children, especially when we are doing serial follow-ups. So in case a lesion has been diagnosed, a bone lesion, and characterized well from CT, we can do serial follow-ups using MRI technique, using this zero-T technique. So this is just for brain, and we can be able to get rendering, substandard. And that's the end of my presentation. In case you have any question, you can ask.
Thank you, Dennis. We want to combine Dennis and Washira.
Yeah.
Let's start with someone.
So he is still in. Ashira is still in.
Okay.
If you have to ask question for Ashira, I think one has to use the mic here. However, you can check whether he
Can
has.
you tell the guys who are online to maybe write down their questions?
Say that. You don't in and now.
So many you can take care. So if you have any question for Ashira, you'll have to come to the side. So for Dennis,
Yes.
Presentation. So for me, I'm looking at it from the perspective of at what cost are we getting this software? Is it affordable? Because the reason I'm asking you that, we have like an MRI right now, the cost of the software is very expensive. That when the exam is less for the we can't even justify. So, at what cost is this technology? Is it affordable? Secondly, can we do without it? That's the guy. Can we do without it? Because I also have two questions that were not answered: the injectable part and recycling component. Because these are we're looking at cost effective. We have to go to the very some of us to justify all this. So that's my question.
My boss wants to buy pets. So what about this one? We can do it. I like that. So the answer is faster. Any other person? I think your partner.
Maybe I can answer as I wait for another question. So the first one was on cost. So these are solutions. So they have to address a problem. And I may not be able to give an answer that will apply for every center, but we have to be able to know the center, what are the challenges do you have? And then from there, we can be able to offer these solutions to solve that specific problem. Definitely, I haven't added every other advancements that are available. There are a lot of them, but what is your current challenge in your department? And then from there now we can know that, do you need it? Because if you can run without it and it's efficient, and then you don't need it. But if there is a challenge, let's say patient number, improve image quality, sometimes you see like you have a 1.5 Tesla MRI, And the image quality is poor. You want to do a lot of prostate examinations. So the challenge becomes, do you have to remove that 1.5 Tesla and then buy a 3 Tesla MRI? You compare that cost and using this AI deep learning algorithm to denoise that image from 1.5 and get improved image quality, which is almost comparative to 3 Tesla. So I think it is a case by case approach.
Najua kuna siri moja hataki kusema bwana. Ule bwana at what costs? But you must start your question now. This will be at approximately how much it is, you know? Sisi kwa serikali tunaweza kwenda kulia tuenda Dubai tupata wafadhili sio? Lakini lazima tuambie approximately how much is it? Then we know whether it's worth it or not.
I've mentioned a lot of things, so we have to know which one, and then we can discuss.
All that you said, they are put together.
Honestly, I don't know. I cannot be able to answer that.
Okay, thank you very much. Any other question? Yes, my brother. Lakini ulisema wewe tutaua wagonjwa. Sasa sio.
My question is, you mentioned of several applications. Are these all applications combined together that we can put them in one software system and install if the current machines we are having at our workstations or of different, they come specifically with different machines so that we can spread the cost and pick them at different level of practices, or we can have them all in the same machine, also upgrading the machines we have, or we just need us to purchase new machines. We want to help to get awareness with the facilities we are having, the management and the rest of them.
Ama can we upgrade what we have and put in some of these things or all of them?
It's hard to give a straight answer for that, because first of all, are you using GE system machine? Because the solutions that are presented are for GE systems. So if you have, and then what is the software level, field strength? So some of them may not be compatible with all systems, but for the newer system that we are giving now, they are compatible with all these solutions. So you can buy a new machine and put all these enhancements into that machine.
Any other questions? Any for Ashira? My friend, ule mtu unaotikiswa ule kuna matunda sio? Na pale kuna mazuri ndio kila mtu anaenda. Jamaa maswali mengi kwa sababu anataka ile mazuri lakini hauwezi kwa telefoni.
So how many are excited about the bone imaging? These are new technologies, and for the future, maybe some of them are available with other vendors. So if you're using other systems, you can discuss with the vendor. They can have some of them, but some of them are only available in G systems.
Maybe also you can have some sort of value addition of image. Some of these researchers that are picking up. We had Philips installing the software because we're doing research. So you can pursue that. With some research.
Thank you very much, Dennis, for that good presentation. we have some difficulties for those guys online, and I don't know, I think it's technology, I'm a network, but for those guys who are down here, they've done a wonderful job. Can we, Dennis Mama, but we need to appreciate you. It's Christmas time. It's Christmas time, yeah. It's Christmas time, sasa sisi nataka kupatia Dennis a gift ya Christmas. Sasa chukue hapa, ifunge vizuri, tengeneze vizuri. Mwana Dennis ako wapi? Ile Christmas tree iko pale, sio? Unafanya nini? Sio? Haya. Hapa vizuri. Pelekana na mapenzi yako. Sio? Chagua gift yako, unaweka ndani, unalapo vizuri. Unaangalia Dennis hapo kufanya nini? Chukua. Thank you, man. Kwa hivyo siwezi sahau kwetu. Nadhani tumefika mahali pa kuwa sasa niregeshe usukani kwako ama nialike nani? Sydney.
Okay, thank you. Our moderators have done quite well. And they deserve a clap. Is that true? So let's give them what we are common with exposing, but this time we just give them. We'll just expose one, okay? We are proud of being radiographers because that's where we started. And this one we don't do because we want you to go and expose yourself. Our moderators, that is Mr. Sang, Madam Lucy, and Mr. Gigi. So let's prepare. We normally do it like this. Let's prepare. We'll do it in a style that I normally do it in my house. When you come to my house, the young guys, nowadays they are called alpha. They have a way of appreciating. Like Mr. Witi has received this severally because he always brings them a juice, which is in terms of Kericho tea, well breaded, okay? Lemon, all that. So they normally do that, prepare, just pamba, and once exposed. Thank you. So, and to our speakers today, starting from Esther to Dewa, Martin, and Tabot. This is our own. They are radiographers like us, but today they had the baton to have a chance of presenting to us. So the same thing that for them, I think we need to do. There are how many? There are 4. Is that true? So once we prepare and now we are going to expose, we do a factorial of 4 going downward. Okay? Here, that's where we measure concentration. So don't start 1, going 2, 3 when others are going down, okay? Let's go there. So prepare. Look to your neighbor whether he's together with us. Then Bamba. Then factorial of 4. Let's start. 1, 2, 3, 4. 1, 2, 3. 1, 2. When? What's happening there? This side, I think there is one who is adding one more. And Dego has decided also to give you a nest to say thank you on this side. It's well done. And to G presenters, we had Dr. Olanch. Of course, we understand in absentia, we understand the challenges of technology, but we are managed. We are trying to maneuver all these things. I've noticed if they are not hearing me, even the ones who are located to do these things, they are having the same challenges as what we are seeing, though we are on the other side of the medical field. But I think we radiographers are do multitasking. Within this field, I think I've learned a number of things, and the more you present, the more you get used to these gadgets. So we have done quite well compared with other areas where we have been. So for our presenters, e.g. Dr. Olaj, Mr. Wachila, Wachila was my boss in Nairobi Hospital where Martin's work. You sit in the same office. And then our own, the youngest, Kibet. He is doing well, is that true? Yes. Having joined the field just another day, with what he is saying here, and he is challenging us with the new technology where we are going. Let me tell you one thing. So when PACS was being introduced and was coming here in Kenya, I think I witnessed most of our colleagues fighting it. And I think in this house, whether in this Kenya, I don't know whether there is anybody who got a good fight like me. I was in a hospital by then. So that was another story, okay? That this system is coming to take us home, because now the reportings will be done elsewhere, and the issues of manual thing will be over. Imagine they are even reporting when you are sleeping. So you wake up, the young tasks are already reported. So, but I remember the ones I said, our seniors who are now our radiologists, that you can't fight technology in any ways. As long as we are living in this world, technology is here to stay with us, to grow with us, and it's growing on a daily basis. So a lot has come, many things has come. AI is here with us. You remember the story of AI? Everybody wants them to present on AI. And the questions were there is it not coming to take over from what we do? Technology has its own space. The morning's presentation was on point of care ultrasound. And this is technology. Is here, is in the world. You can't fight it. But what do you do about it? What Martin presented is now radiographers going to the next level. You know, where we only used to know to say that we need only to know AP, lateral, oblique, caudal, something like that, serial, cranial. I remember one of the view that Martin was my classmate. We were not taught when we were in class. And the first day I reported somewhere, I was asked to do a perineal sort of an MCU. And I didn't have a clue of it. I really found it loud. It was a perineal sort. I don't know how many knows that. I have never forgotten, because I was sacked for 2 days as a young radiographer too. Nilikanyanga nyumbani. Said, do a perineal sort. Mgonjwa sahi amejaa kwa choo. I have no idea. So we went to one of my classmates who was bigger than me and just reported 2 days. And within the corridor was called, come, do this. That is Alison Owo. Do a perineal sort. Do you know? He said, no. So that's when I noticed that there is a lot to learn. Life is like that. So technology is here to stay with us. Martin, I'm not surprised that even what you are asking is we are only limiting ourselves. It's true there are not those ejector pump synchronized to the equipment, either maybe because of risk or what we have seen with the contrast, but we still have a room. We cannot limit ourselves. Maybe very soon you'll find some of the vendors who are developing those equipment, and at the same time they have inbuilt system where is a one-stop thing. When we were in college, Madam Joe knows that city, you'd start it on that side, then go and wait on the other side. So you kept on moving on that room. Is that true? Yes, he has that story. So the same thing now, it's a one-stop place where you can work with a mouse. So we are not limiting ourselves. So with that said, I don't have a lot. So I'll give somebody to say something. That is Alex. He is the head of the radiography in departments in Kenya, in KMTC. And I think it's good we hear from him what he is offering as head of that area. And we can also ask him questions because we are the one who are having this, the young people in our area. So the opportunities that are coming in, what is there, how is he preparing himself, because he is the one to work with us when we are getting to this thing we are calling board. He's coming with some regulations. How good are we prepared on that? And are we prepared for what Dennis is saying, what Martin is saying, what Esther is saying, and the rest of the presenter? Welcome. A few minutes.
Thank you, Sydney. Good evening, everyone. Yeah, I know it's that point in time where we really want to go. We don't want more stories. So I'll be very brief. And first, I want to say thank you very much, Sok and G, for the opportunity. I would not have met all these people if it were not for your effort. And G, particularly, I think we have walked a long journey this year. Ken, you know, we started in Nairobi, we went around this country and finished in Nyeri just last month. Thank you very much on behalf of the college. Of course, we appreciate a lot, and we are looking forward to the collaboration to continue. Now, KMTC, as you all know, I think most of us here have gone through KMTC. The program of radiography and imaging in KMTC is growing very fast. I remember during our days, we only used to graduate about 20 or so. I have several classmates here, by the way. Sydney is one of them. There is Martin, there is Catherine, there is Nicholas there. So I have several classmates here. Kwenye tulikuwa darasa, those years. I'm saying that KMTC's program of radiography is really growing. Now we are graduating from the 20 we used to graduate. Today we are graduating 400 every year. Just the other day, that was last week, we actually graduated over 400 radiographers to the field. And what does that tell us? That are we having a cake that is enough for all these people? Are we having the cake that is enough for all of us? Yeah, naona watu wanasema no, locums zimepungua sababu vijana wamekuwa wengi uwanjani. What are we doing as KMTC? I think it is high time. I'm one person who believes that let us congest the lower part so that we can push people up. Wacha wakuwe wengi wapa chini, basic qualification, so that more of us can come and specialize. And therefore, as KMTC, today as we speak, we're offering about 4 specialization programs. We have a higher diplomas in ultrasound, CT, MRI, and radiotherapy. Ultrasound is in Nairobi, Kisumu, and Eldoret. The applications and intake are usually done in March and September. Nairobi, we concentrate doing it in September. We have left March for Kisumu. Eldoret is just coming up. We accredited Eldoret the other day. So we are yet to decide which intake they are doing, but this year I think they did a September intake. And for Eldoret, it is open for all the programs I've mentioned. Eldoret can now do CT, MRI, and radiotherapy. Of course, we are taking advantage of MTRH as a primary training facility. How are we offering these programs? We are leveraging on technology. These students don't have to be physically with us every day. But of course, you know, training, we train, we give knowledge, we also have to give skills and attitude. So in terms of knowledge, we allow the students to attend classes online. But in terms of the skills, that is when occasionally we need to have them on physical sessions. So we have structured our program such that only 30% of the content is theoretical. 70% we are concentrating on the students having the skills. Remember, KMTC recently revised its mission to training fit for purpose. So fit for purpose means these are people with the required skills. If you're talking of an MRI, I don't know whether to call them radiographers or MRI technicians, we are talking of people who can handle everything MRI competently. What we are having today is people who are trained in everything. And therefore, you can touch CT kidogo, you can touch ultrasound kidogo, you can touch general kidogo, you can touch everything else kidogo kidogo. Tunataka sasa kufika hiyo kiwango ambayo kama wewe ni MRI, when MRI is mentioned, like today we mentioned CT, I think all of us agree that Martin, anything CT, I think Martin will give you an answer. That is the kind of people we need to have in this profession. Our programs, of course, are 2 years. The higher diploma programs are 2 years. I know there's a lot of debate about it. But that is a requirement by the Kenya National Qualification Authority. Kenya National Qualification Authority signed some agreement with KMTC, and therefore we said that we are graduating higher diplomas with what we call equated to level 7, equivalent of a bachelor's degree. The question is, do we then issue bachelor's degree? No. KMTC is not mandated to issue degrees. We issue higher diplomas. From this graduation we had last month, we issue higher diplomas equated at level 7. And if you got near KNQA offices, then they can actually issue a document equating your higher diploma to a bachelor's degree. Of course, we are foreseeing a future where we have people working in MRI, CT, ultrasound, and radiotherapy as people with the papers, qualified with papers. So I'm here to encourage all of us that please pick your line. KMTC is ready to receive you and give you the necessary skills and knowledge. We developed our curriculums and they are the best, I can say. Martin here can attest to that. We had a workshop where we developed the curriculum. I think Tabot, you were in that meeting. We developed and we tried to put what is necessary in those curriculums so that we give the graduates the required competencies. For diploma, of course, we are also expanding. We now in 8 campuses. I mean, we were in 8, now we are in 10. Tumeongeza Homa Bay, tumeongeza pia Siaya. There's a lot of pressure with this course. Sometimes there's a very thin line between what exactly do we want. Do we want enough numbers to cause an impact, to cause recognition in community? Or do we still want to maintain our numbers and therefore struggle getting recognized? Yes, I know it comes with a lot of requirements if we have to maintain the quality and standards. Of course, we are not opening ovyo. We are opening with careful consideration. If I had somebody from admissions office of KMTC here, they will confirm to you that the applications that are received for the program are now matching the applications that are received for nursing and clinical medicine. So the college is receiving a lot of applications. Every other day we meet principals, they're asking why the program is limited. Why are we not giving Kenyans an opportunity to train? Kwa hivyo pressure ni mingi, the course is now known and people are really applying and they are applying in their numbers. Finally, Sydney, I think I will not talk about the board that is coming. I think Owit is here to talk about the board, but as a college, we are prepared and I know what is expected of us. We will be represented, I think, in that board. And we are aligning. For us, of course, is training. And we will ensure that our quality of training is up to standard. What I call upon members here, without using so many words, is that I'm requesting for your support. The college only offers theoretical knowledge in class. But when it comes to the practical skills, nyinyi ambao unawaona hapa, tunawategemea sana. Please hold the hands of our students, especially when they come for clinical placements. Let us mentor, let us coach, so that it is a collective responsibility. But there are times when I felt like we used to refer to students as hawa watoto wa KMTC. Hawa watoto wa KMTC, sio wa KMTC, ni wetu wote. Sisi tunawapea knowledge pale darasani, wakija kufanya clinical practice, I think we play a part in it, and therefore please, I beg you that we continue cultivating the radiographers that we want in this country, and let us instill in them the sense of continuous and lifelong learning. Asanteni sana. Thank you very much.
Excellent. Then I will call Kenneth on behalf of G for the few ones. Very soon we should be leaving this place. We are past time. I think it's either 2:30 minutes to be closed.
Yeah, nizo.
But that doesn't give you a leeway to keep us.
No. Me, I think I'll just finish our part because Sydney gave a vote of thanks, isn't it, to the speakers, to the moderators, and also to each and every one of us for being so patient. I think that's the zeal we need. When you have an opportunity to gather like this, I think it is always wise to just hold on and get as much as you can. And that's what exactly we have done. Of course, some of us, like myself, I dozed, I think, for 5 minutes, and I think it was enough because I woke up very well. There's some who did 10, but I wouldn't say who. And one did 15. Yeah, so I think I was the best in terms of doing 5 minutes. And Lucy didn't sleep as well. You didn't sleep. So thank you very much. SOC leadership, we hope to see how the year progresses. And then next year there is Pakori. We'll try to find a space, God willing, for ourselves. So that we can have a very focused discussion like this one. For the G team, Dennis and John Washira, it is always good when you are able to have that opportunity to specialize in that way. You come and download for us once in a while. our mom, Mrs. Njue. Yeah, you are at some point when you were starting college, you were the epitome of CT. And every time I see your name, I remember how we started in the profession. Alex, you're doing very well as a leader. I've interacted with basically almost all principals, and somehow I think you are the youngest. And every time you miss a meeting, all the principals know. And there's a time they made some noise. Said Alex was not in that meeting. So keep representing us well. We appreciate what you're doing. Of course, on ourselves in the industry, we will keep also representing radiography well in whichever way God wants us to do it. Our managers, we also appreciate you. Please, I know it is not easy when you are within a meeting of managers, but I know you are lucky it's radiography. Sometimes radiography are able to easily differentiate, and there's nothing important as a differentiation. It makes you ahead of the pack, other than generalities. So we also wish you well, Esther, Martin, and Galgalo. For Galgalo, I know yours has been a tough battle, and Owiti, for your counties to be having, I think, among the few counties that are having the right the progression. It is never easy in the county politics. So please, we also appreciate you. And whenever you have an opportunity to whisper something on how you are surviving to the young ones, please do. We don't want when you leave and whoever is in charge of this Mombasa County or Kericho, wanakuja wanaambiwa, oh, we don't have budgets. And then they say, yes, sir. So please, we appreciate you as well. So Sydney, I think we are finished. So thank you. Let us also appreciate Sydney. He does a lot of work to just try to connect with all of us. Myself, sometimes I'm not able to do so, but Sydney is always there. Please support him. I request your support. Usimuangushe sana. Itabot. Na ulisema ni helium. Nimefanya ni helium.
Thank you, Kenneth. And I think Kenneth, I report to Kenneth for those who doesn't know me. So sometimes it's not easy. You are the treasurer, and you are going to ask money from your boss. Okay? You need still the same justification like what I've done with KR, cardiologists, students, both all the colleges and any other institutions. But I think he has done well, and we are able to balance what is in the market. So Kenneth, thank you. And once we knock again, kindly give us money. And the reason why you see we are not many. The money was small. So maybe next year allocate us more. I think we'll be more well organized, maybe early the year. And I'm happy you are part of the radiographers. You can remember Pakoli. It's coming next year. So next year we are speaking of Pakoli. For those who doesn't know, we don't have LASCO. We are doing a combined conference. That would be radiologist KR, SOC, and other partners like physicists, and those who may come in. And it will be the month of September. So even if I come knocking the doors, because I'm the resource mobilizer for that conference. So once you see the service providers there, kindly be our ambassadors. Tell them that there is a big conference where you can market yourself very well. It will be in Nairobi, and that you do very well for us. we also expect you to participate. In terms of presentations, what we are doing, Martin is in that, in the committee of the Congress, is that true? For the scientific, those papers. And I think Cesar Barada and Dr. Kira, yes, we are strategic. The council was very strategic. We lobbied very well. Karibu Kiumane. So that once they, see, it's also there. Yeah, okay. Once they ask for the abstract, let us be the first to give those abstracts. Our own people are there, and they are there to make sure that we have good representation, and even as we hear from the rest of our partners. So not taking much. On the side of the treasury, I know all of you are waiting. You had a promise, or you have promised something. So we few minutes, you give us a few minutes once we are done. We will reconcile with Oscar. You can see how much work he normally does, because he has to do a very good enter of the numbers you gave. So if you give the wrong number nowadays, so don't blame me and don't blame Oscar. Takuwa imeenda kwa neighbor. So that's what he is doing back there, for us to be able to compensate for a few things. Good to say that those who are coming with Nairobi, we didn't spend a lot. We only carried on few members from up country, I think around 14 there, due to what we got from Kenneth. But we hope, and this is our prayer, once we have enough resources, it's more expensive to bring you on this side. As a council, we are recommending that we'll take them regional wise. So however, we still carry some other people from this side so that we can have that interchange program. Okay? So God bless you. With that, I'll call Mr. Owiti to come over and now do the few ones from SOC and where we are. And when you go there, be our ambassadors. You must have realized a lot is happening. We are spending a lot. I agree with that. But we are streamlining society to be that picture each and every one of us would like to be. For those who are in committees, when you see us harassing you week after week, Mr. Alex, and Martin and the rest, and the youngest is him, Benjamin, who is the Secretary of Scientific. So that's where we want you to go. So I brought Benjamin here, and the first thing I told him in the morning, what we are doing here is what you should be doing as a scientific committee, and you make sure you compile your data very well and put it in the manual, in the journal, online, such as those who didn't have an opportunity to attend, they have also equal opportunity to listen and to hear what we have received here. Sio Diojia. So support us, and where you can correct us, we are here. We are happy. Call us, challenge us, correct us, invite us, like John there last Saturday. And all the questions were difficult for me, so but we managed to tackle them. So asanteni sana for coming, and once you go back, salimieni wenzetu na wale wako huko, na make sure you share what you have received today. Thank you.
Once again, I want to take this opportunity to appreciate all of us who have attended, and also extend our word of appreciation to the General Electric that is represented here through Ken and Sydney. I want to say thank you so much for the partnership, not only now, but always. You've been very supportive. I want to appreciate those of you who took an effort to come to this place. I know we have had an engagement. as Sydney has said, let us go out there and be ambassadors. Let us tell our colleagues to work with us. We have very good news. I just got an engagement this afternoon that there's a lot of pressure from the AG that our board be put in place. So it's a lot of pressure from her that she wants to comply with the court order. So let's keep praying and hope for the best. So we are moving on the right track. And I want to assure you that it's coming to happen. It might happen sooner than we expect. I want to say that now we have chapters, and we're also encouraging our colleagues to form branches, because now we have the Eldoret branch. Eldoret branch, they did a request, and they are moving ahead. So from wherever you come from, if you are from the north, south region, or Mombasa, you can do a request to the Secretary General of Society that you want to have a branch, because that is expected, because that is in our constitution, that we need to have branches. So Eldoret has already taken the queue, they are ahead. So Lydia, Nairobi can do a request, the regions can do requests so that we have branches and we can articulate our issues at that level. So that is our running call, that we do that. As Sydney rightfully said, that next year we're having Pakori, and we're working together with KAR and other stakeholders. And then we were supposed to have RASCO next year, but now we decided to collapse the two meetings. And then RASCO will be in 2026 in Kisumu, because that's what we decided when we were in Mombasa, that RASCO will be in 2026 in Kisumu. So those are the upcoming conferences that we need to think about and do resource mobilization. So again, I want to say that our board will be very, very engaging, because we want to regulate practice and training. So we'll do away with the quacks. We don't want to do a combative engagement. They'll just fall out because of the issues that are there, because we will do regulations that will help us run the society and the radiography. So I want to tell all of us that we have this council. I know the agitation has been there, even Ken when he was president. They did a lot. I remember when they used to see Majority Leader Ishongwa, and they realized that our bill was a money bill, but they convinced him. So it's been a journey. So as we come to the tail end, just know that we are going to have a very, very robust board that's going to do their work, and then we'll have our radiography up there, because now people will listen to us. I'm glad that the government in place now, the CS Health, the people who are supposed to help us are really doing their best also. So we have had a high-level engagement this afternoon, that is a lot of pressure from the Attorney General that the board be in place sooner than the ruling that was given, because the ruling said that the board should be in place within 60 days. But the AG is pushing that it should be there the earliest possible. So keep praying, and it will come to happen. Otherwise, I want to say thank you so much on behalf of the council. Remember, when we talk about SOC, SOC is not the council. SOC is any radiographer who is registered. All of us are SOC. So when you hear somebody saying, what is SOC doing for us? Ask him, who is SOC? SOC is you, SOC is me. We only have the council that's helping us steer. And as has been said, we have an open policy. And we have a lot we are doing behind the scenes sometimes. We have night meetings in the committees. We travel a lot. We do a lot behind the scenes. But soon we are going to deliver. The outcomes are going to be very pleasing. So I want to appreciate all of us once again for coming. Thank you, and God bless you. I didn't bring tea, but next time when you come for our meeting, I'll give you tea. Very special tea for export. Those who come for our meetings, they know they normally get tea, special tea. So, and I believe some of you have gotten tea from Kericho. Yes. So we can stand and say a prayer, and then we believe that when you are called next time, please come. And we appreciate you again for coming. So let's pray. Father, in the name of Jesus, we want to thank you once again this evening for this wonderful engagement we have had this day. Thank you for our main partner, General Electric, for the way you have given us favor with them. We continue praying that, God, as we move, as we close the year, we want to say thank you for the many things you have allowed us to achieve, and even what we are anticipating to happen for our board to be in place, it shall come to pass for the glory of your name. Thank you, Lord, for those who have come. As they go back, we pray for Johnny Masters, divine protection, that this profession shall be a noble one, because, God, you are on our side. And if you are on our side, none can be against us. We declare favor, we declare anointing, we declare long life. We pray that, God, your word that says you wish above all other things may prosper, be in good health, our soul prosper. That will be our portion, dear God. We want to bless and worship you. For those who served us in this hotel, bless them together with us. We want to bless and worship you. In Jesus' name we pray. Amen. And now may the grace of our Lord Jesus Christ and the love of God and the fellowship of the Holy Spirit be with us now and forevermore. Amen. Thank you. God bless you. Greet your families. Let's meet again. There is tea. There is tea on our right side. Please take tea before you leave. There's tea. Take tea before you leave. Thank you.